Spring is in the air. Welcome to the Urgent Care Association Solutions on Demand webinar brought to you by HealthTrack RX. Today we're going to talk about the role of rapid multiplex PCR to optimize clinical decision-making for outpatient infections in the urgent care. We're going to discuss cases today that are unique to spring and summer. Kids come home from spring break, we see an increase in STIs, and as temperatures heat up, traditionally there's an increase in urinary tract infections as well. I'm your moderator, Ben Favre. So to get through these cases today, we're fortunate to be joined by two experts in molecular infectious disease. First, we have Ali Prego, a clinician at Modern Pediatrics and also a medical science liaison at HealthTrack RX. We also have Dr. Stephen Goldberg, who's an urgent care practitioner at University of Louisville Health and is also the chief medical officer of HealthTrack RX. Let's move to our last case. So here we have a 78-year-old man transported from his assisted living facility with a 6-day history of dysuria, urinary urgency, and chills. On history, patient has a chronic urinary catheter secondary to a neurogenic bladder, has diabetes mellitus type 2. The patient is alert, oriented, not toxic, temperature of 99.2, heart rate of 90, respiratory rate of 18, 98 on RA, no abdominal tenderness, back or flank pain, or controvertible angle tenderness. The urinary catheter is in place. This is a complicated patient here, Dr. Goldberg. What are your initial reactions when you see this patient in your urgent care?
This is a complicated case, Ben. And that's my first reaction. And I want to make sure I get it right. And I want to make sure I can safely diagnose and treat this patient in the outpatient setting and in an urgent care setting. So to start, in this case, the patient is 78 years old. What we're aware of is that in the United States, we're confronting a silver tsunami, which is about 11,000 people becoming 65 or older every day in the United States for the next several years. We're aware of shortages in terms of access to primary care, GYN, internal medicine. So we and our urgent care colleagues are likely going to see more such cases and more complex cases. So we just have to be prepared. Diabetes is quite prevalent. It can lead, if you have it for a long time, to a range of comorbidities and consequences, including neurogenic bladder and including the need for an indwelling Foley catheter. But having an indwelling Foley catheter can put you at risk for bad stuff very quickly. So let's look at this case and try to tease through it. We're seeing a mixed picture in terms of us trying to gauge how sick this person is. So it's good that they are alert and oriented and not toxic. That's good news. They've got a bit of a fever. Their heart rate is a bit fast, but their breathing is not fast and their oxygen is good. So it's not suggesting that they are toxic. All good news. And as you described, the abdominal exam is unremarkable. At the abdomen, at the flanks, at the costovertebral angle, which can get uncomfortable if the kidneys start getting involved. So that suggests we might be early, and that's good. And then the urinary catheter is in place. Now, what's not described here is how long the catheter has been in place. But if it's been in 2 weeks, it elevates your risk of more generalized problem.
Very good. Dr. Goldberg, what's your differential here? And what are the diagnostic techniques that you think would best fit a patient like this? And this is one of the areas where there is controversy. So help us understand why you're picking it and what are the options?
Well, Ben, the thing that I'm thinking with a lot of energy as I'm in the room with this patient is trying to assess how sick they are and how broad the infection might have gone beyond, say, seeing if they have it in the bladder. So I'm concerned if they have an early pyelonephritis that it extended up to the kidneys. And this person certainly has risk factors because of the indwelling catheter for having multiple organisms in the bladder as pathogens. Yikes. And it's not uncommon that these multiple organisms can be antibiotic resistant gram-negative organisms, such as E. coli and others. So that's a concern I have. So then I need more than my own thinking to help make an assessment of what's going on. We'll take a look at a urine dipstick, a urinalysis. We'll consider a urine culture. But the problem is the urine culture is going to take multiple days. I'm concerned that this patient's condition can escalate fast. So in my opinion, I can't wait for that. And that's where multiplex molecular testing, looking for multi-pathogens with rapid result turnaround, can help me do best care for this patient. So I'm going to consider a multiplex urine PCR test in this patient.
Excellent. So with that, Dr. Goldberg, walk us through your diagnosis and what you've done and where you think this patient's headed.
Well, Ben, we thought about what's going on, mild to really sick. We're concerned about progression to pyelonephritis or urosepsis, which can be life-threatening. So we're going to go ahead and get that multiplex urine PCR test. And our results show in this patient that they had multiple gram-negative organisms, E. coli and Pseudomonas. And sadly, in terms of risk profile, they were multi-drug resistant. So that's yikes and yikes. Frankly, I need help in terms of consultation on the therapeutic planning in terms of antibiotic regimen. Possibly this patient with careful follow-up can be managed as an outpatient setting, but there's going to be a short trigger to escalating the level of care depending on how they're doing in terms of their vital signs in response to therapy.
So this is where you phone a friend, right?
Phone a friend, absolutely. And don't feel bad about it.
I think that's a great call right there for this type of patient, for sure. So Dr. G, walk us through from a population health perspective. Earlier, you mentioned the silver tsunami. Clearly, we're going to be seeing more of these patients. Help us understand, where does PCR best fit in, and when does culture fit in or no testing fit in?
Well, catheter-associated urinary tract infections are going to be something we in the urgent care setting are going to see more of. We need to understand the morbidity associated with it. Bacteremia occurs in 5 to 10% of patients with catheter-associated urinary tract infections. That is high. That is a lot. That is a bunch of folks that can get sick and sick real quickly. The risk factors are long-term catheterization. So if the catheter is in there longer than 2 weeks, if they're elderly, if they're immunocompromised, if they have diabetes and certainly progressed diabetes. And a major thing that we can do is if someone needs to catheter, hopefully they've been coached and managed about how to do very good personal and local care of that catheter. There are several pathogens. We list 5 here that are associated with the bug. And we mentioned preventative measures. So in terms of PCR, there is accumulating evidence about the value of PCR and multiplex PCR to help make upstream diagnosis accurate, reduce downstream visits, and total cost of care. Now, for me in the clinic, and someone who I know from reading is at risk for multiple organisms and multiple resistant organisms, I want to get that answer fast. I don't think I can wait several days for a culture. So to me, this is a profile that's excellent for the use of multiplex PCR to help get the diagnosis promptly and an effective treatment plan, given the morbidity that we're confronting in this profile.
Great job. Thank you. When managing a patient with suspected UTI, what is your usual approach to initiating antibiotic treatment? Allie, I'm sure you see a lot of UTIs in the pediatric population where you work primarily. Any tips on UTIs in that population?
Yeah, kids can be tricky where, they may not be able to, depending on their age, be able to tell you exactly what's going on. And we just have to make the best guess based on their history and exam if, we're suspicious for UTI. So I really, really have to rely on, for those really young patients, on like initial point of care urine dipstick or urinalysis testing. If I get a really good specimen and it is completely squeaky clean negative, it makes me more reassured that maybe I need to go look on and figure maybe it's a different diagnosis. Maybe I need to go on to a different path. But if that point of care test is fishy at all, or I'm looking and there's a lot of leukocytes or nitrates, I really have to investigate that further and be highly suspicious at that point. And I think kids also, kids, they can be prone to pyelonephritis. They can get sick very fast with UTIs, especially febrile UTIs. So Like that patient that we just discussed, I always have my guardrails up, my red flags up with the little ones coming in. So I really rely on my point of care testing, and I really need to confirm it. And kids can get sick fast. They could look really well and they get sick and decompensate fast. So multiplex PCR is a really good option for those kiddos as well.
Thank you, Allie. Dr. Goldberg, any closing thoughts on this case or the survey results?
Yeah, Ben, I would say I talked about one spectrum of age and morbidity, and Allie talked about another spectrum of age. There can be people right in the middle who have no complicated medical history, have classic cystitis symptoms in a female. We get some insights from point of care testing. We know about the resistance in the community. Let's hope it's not high. We're probably safe to initiate treatment just with that information and then do some follow-up afterwards. So for folks in the middle, they're probably okay with historic established point of care testing. It's when you get at the spectrums that you want to consider something else, especially in the elderly where the morbidity risk is very high and you got to get it right very quickly.
Yeah, the sicker the patient, the more that ability to wait and the need for answers to be right really kind of gets amped up. Great conversation. Thank you both. This has been wonderful. Really appreciate y'all's insights. And thank you everyone for attending for the Urgent Care Association Solutions on Demand webinar brought to you by HealthTrack RX.